Hello, good evening, everyone.
Good evening. Hi, Bhavesh.
Hello,
Good
madam.
evening. Good evening.
Hello.
Hi.
Rajesh hasn't joined. Saurabh, please Rajeshला फोन करतोस.
हो. करतो.
So just for an informal discussion, in 2 minutes we will start. So the simulation centers are there at lot of places. And it looks like it's a necessity for medical colleges. So
The National Medical Council has made it compulsory for all medical colleges to have a skill lab. And we can perform these simulations in the skill labs. And even for post graduation, now they have made it compulsory to do trainings in skill lab. So actually, over say you can say last 5 years, all medical colleges are having good setup of skill labs. So students are learning in a better, say, environment and safe environment. So it's really a good practice. But I would like to say in the discussion that even freelancers, they should practice these simulations not in the form of actually on mannequins, but they can do mock drills or they can perform case scenarios like that. So that
yes,
is
so that's
really
what
going to help.
actually, you know what the private practitioner seems to think that I mean simulation हमें क्या जरूरत है कि
हाँ,
देखो
but
हमने
it's
सब
not.
किया है अभी
हाँ,
इंट्यूबेशन हमें सीखना नहीं है. So I want to burst some of these myths, and
yeah,
I'm sure you all will
yeah.
agree that we can do a
See,
lot
if there is some maternal collapse or some arrest in the OT, then you're not that expert or like what steps you should follow, how to go about it. It's a critical situation, but not it will not happen so frequently. Na? It's a rare occasion to have this situation in OT. So for that, you should be trained. आपल्याला वाटतं आपल्याला सगळं येतं, but it's not so when the actual situation occurs. That is why it is important.
yes. So Saurabh, Rajesh is joining.
म्हणाला जॉईन करतोय म्हणून.
Good evening.
Yes, hi Rajesh, good evening. And
Hello.
35. So we start right away.
Yes.
Yes.
Yes, please start, Rajesh.
Good evening, all.
Good evening, sir.
Today's webinar is on simulation anesthesia, and we all know that simulation is coming forward very fast and very useful in the anesthesia. And all over India, ISA National is trying to go for simulation workshops all over India. Till now, so many workshops we have arranged. And today, in today's webinar, Dr. Sauni Futane will be talking on introduction on simulation, and Dr. Vaibhavi Upadhyay will be talking on use of simulation to navigate difficult airway algorithm. So I would like to request Dr. Anita Nehte Madam to brief about today's SAM symposium.
Yes, thank you, Rajesh. Actually, SAM Symposium, we have kept the theme as Safe Anesthesia Saves Lives. So safety simulation has a very, very important role to play in the safety of the patient as well as our own safety and safety of an anesthesiologist, yes. So as private practitioners, most of us ISA members are private practitioners, and we seem to think that simulation is for sort of postgraduate teaching. And what is in it for us? So is the simulation as a principle of simulation useful for private practitioners? Can we you do mock drills, and can we enact, or can we have some critical care scenarios so that we are better equipped when such things happen? Suppose it's a maternal collapse, or cannot intubate, cannot ventilate situation, or a local anesthesia systemic toxicity situation, which are not going to happen daily, but which are once in a lifetime situations. And if you, with the help of simulation, you can learn, you can teach, and be better equipped when the situation happens in your own life. So do we need only high fidelity mannequins, because they are quite expensive for understanding or learning simulation? So all these questions we have, and we have very learned faculty today. So we will start, and I I want to introduce Dr. Sunita Sanklecha, our chairperson. Yes, Ganesh, please display her CV. I'm very happy to introduce Dr. Sunita. She is a close friend for so many years, and she has done her MD anesthesiology from GMC Aurangabad. And she is at present a professor and head of department in the Department of Anesthesiology at Maharashtra Postgraduate Institute, Nashik. And she has been a HOD for Vasantrao Pawar Medical College, Nashik. She has a total teaching experience of 32 years, and she has also been ISA Nashik president, and she has a key role she has done in all the development, all these programs like simulation in all the medical colleges that she has worked. So welcome, Dr. Sunita Sanklecha.
Yes, thank you, Anita. Thank you so much.
Yes,
Now, next
Dr.
slide.
Kalyan. Yes, please introduce her. She will join us if possible. Dr. Kalyani is busy with some unforeseen situation. She has an inspection going on in her hospital, so she might join intermittently. Yes.
Dr. Kalyani Nilesh Patil ma'am is currently professor in Department of Anesthesia, Bharati Vidyapeeth, which is a deemed university, and she has done DA, DNB in anesthesia and EDR and IDRA courses. She has received Best Paper Award, Dr. M. Deshpande Sir Award for scientific paper presentation in Mesocon 2016, and essay second prize, and have attended Zero Mortality Anesthesia, or it is just Raj, in Mesocon 2019. She is a life member of ISA, RSCAP, ANI, AORA, and ISCCM. numerous national and international publications she has and faculty in a state and national conference. Her special interest is in regional anesthesia and obstetric anesthesia. Welcome, Kalyani ma'am.
Yeah. Now I'm going to introduce Dr. Vaibhavi Upadhyay. She's a very soft-spoken person, boss in simulation, presently consultant anesthesiologist at Dinanath Mangeshkar Hospital, Pune, clinical lead in simulation, simulation center in Dinanath Mangeshkar Hospital. She has multiple achievements. She is a member of CPR committee, patient safety committee, nursing and education committee. She is on managing committee of Bakul Tambat Mayo Nursing College, Pune. She is a certified facilitator and instructor for simulation by WFSA, Mayo Clinic, Lifebox, certified professional behavior analyst, regional director for VAST Foundation and Year and Wellbeing, master trainer in healthcare communication. So many achievements and positions. She is executive member of EORA, executive member of Society for Healthcare Simulation, ex-simulation instructor in the Hong Kong University. She has worked as clinical associate in Hong Kong University. And welcome, Dr. Vaibhavi.
Thank you.
Okay. Thank you, Saurabh. Good afternoon, everyone. Welcome to today's webinar. It's my pleasure to introduce our esteemed speaker, Dr. Savani Putane. She is associate professor in Department of Anesthesiology, GMC Nashik. Her key achievements, she had 11 publications in national and international journals, poster presentation at World Congress of Anesthesiology, Uruguay, book chapter contribution in updates in anesthesia, research presentation at national and international conferences, international best research award she got at International Congress of Research Excellence by International Congress of Research Excellence. Her special areas of interest: simulation in anesthesia, integrating simulation into anesthesiology training, medical education reform through hands-on skill development. So, she will she's a renowned speaker in this simulation topic. So I welcome, let us give a warm welcome to Dr. Savani Putane ma'am, and I request her to start the webinar with her topic. Thank you.
Yeah, Savani, please start sharing your screen.
Thank you for the kind introduction and thank you for the warm welcome. I would like to thank SAMS for giving me this opportunity to participate in this symposium based on simulation and anesthesia. I hope I'm clearly audible so that I can start my presentation.
Yeah.
You are.
You're audible.
Yes,
ma'am.
thank you. Thank you. It is so well said that life is full of surprises, so you may as well get comfortable with the unexpected. And what can be the better place other than simulation lab to get comfortable with the unexpected, uncomfortable situations? We are definitely worried about some such unexpected life-threatening situations. What if my patient gets pneumothorax during IGV cannulation? What if it turns to be can't ventilate, can't intubate situation? What if it is last situation? And what if my patient is malignant hypothermia susceptible patient? As we can't practice these situations because these situations are infrequent scenarios, any delay in diagnosis, error in judgment, or mismanagement can lead to catastrophic outcome. So how to get expertise in such situations? The answer is through repeated practice with the help of simulation. As our motto is safe anesthesia and safe patient, strong culture of patient safety can be practiced by preventing adverse events and by managing the complications effectively when they arise. And both can be easily achieved through repeated practice with the help of simulation. So in this today's symposium, I will try to cover what is simulation, what do we mean by fidelity in simulation, which techniques can be practiced with the help of simulation, and how to create real-life scenarios in our own setup. Simulation is the technique of imitating the behavior of real-life situation to get information more conveniently and to train personnel. So simulation is not a teaching modality, but it is modality to learn and practice in safe environment. So in short, it is immersive learning without any risk to experience real-life medical scenarios. Simulation basically helps in improving patient safety, to increase a clinician performance, and to help in quick decision-making in critical situations. So what are the benefits of practicing simulation? It creates safe environment to learn. It helps in developing core competencies which are difficult to learn on patients, like cardiac compression during cardiopulmonary resuscitation, cricothyrotomy, emergency tracheostomy, or putting the intercostal drain for pneumothorax. These are the core competencies which are difficult to practice routinely on the patients. So these can be learned via repeated practice with the help of simulation. It also improves the crisis management. Then non-technical skills which can be improved with the help of simulation are situational awareness, task management, planning and preparation of unexpected situation, improving teamwork, decision-making, quick decision-making in critical situation. It also improves communication skill, where speaking up, error reporting can improvise patient safety. This is a PubMed paper, Congenital Heart Surgery Skill Training Using Simulation Models. It is not an option, but a necessity. So in this paper, it is quoted that the time has arrived when all congenital heart surgeons should consider surgical simulation training before progressing to real life. It is argued here that simulation training is not an option anymore, but should be a mandatory component of congenital heart surgery training. So even such complex tasks can be practiced and expertise can be achieved with the help of simulation. Here, I would like to quote a real-life example. How impactful is practicing simulation? There is one project, Helping Babies Breathe, which is done with the help of simulation by American Academy of Pediatrics. The HBB project teaches the skills of caring for healthy babies and assisting babies that do not breathe on their own after birth. The result is implementation has been shown to reduce early neonatal mortality by up to 50% and the misclassification of fresh stillborns by up to 25%. Such is the huge impact of simulation in day-to-day practice. This is a life cycle of simulation. How do we create the simulation scenarios? Step 1 is conceptualizing a simulation, which task we want to impart through the simulation. Then step 2 is creating an immersive environment. We can create simulation scenarios inside operation theater, inside ICUs, inside wards, inside OPDs. Step 3 is integrating technology. Which fidelity simulator I want to use, whether it is a low fidelity task trainer or high fidelity simulator, that has to be decided prior. Step 4 is simulation assessment. How the simulation is going on, how the trainees are participating, are they really understanding, are they really actively participating? This has to be assessed periodically. Step 5 is debriefing, where the participants actually give their feedback, what went right, what went wrong, what can be improved further to increase patient safety. And finally, evaluating learning outcomes. Are trainees really getting the knowledge and the skill which is expected to be the outcome of simulation scenario? So why are we hesitant for using simulation in our practice? These are few common misbeliefs. When we have huge patient overload, what's the need to learn on simulators? It needs different special setup to learn on simulator. Simulation is possible only with high fidelity simulator. It's only needed for teaching the postgraduates, and there is no need to practice on simulation for private practitioners. It only teaches technical skills. Let's see whether we can clear these misbeliefs. When we say we have huge patient overload, it is not only about quantity, but also about quality. Are our patients really safe? In one of the articles published in British Medical Journal, it is quoted that medical error is the third leading cause of death. So we have to improve on our clinical skills. Then our patients are not human guinea pigs. We can't keep on practicing our skills on the patient. So there are few situations like malignant hypothermia, LAST, cannot intubate, cannot ventilate, laryngospasm, anaphylaxis. These situations are infrequent and these not at all can be practiced on the patient. So we can get the expertise in managing such patients with the help of simulation. So let simulators help us in improvising our intellectual skill, our psychomotor skill, our communication skill, and good teamwork. When it comes to fidelity, what do we mean by fidelity? Fidelity is the degree of realism which can be created with the help of simulation and its technical complexity. When we say low fidelity simulator, it means the simple task trainer on which the simple tasks like practicing chest compression of cardiopulmonary resuscitation, bag mask ventilation, intubation, IV access training can be practiced. While high fidelity simulators are life-size mannequins that can simulate multiple human functions. High fidelity simulators are able to communicate with the learner through a remote operator interface. So which fidelity simulator should I use while practicing simulation? There is no hard and fast rule, but the only thing is the chosen simulation modality and fidelity should be suited for the effective learning outcomes. So in short, low fidelity simulator is for less complex tasks and high fidelity simulator is for more complex tasks. Scenarios like anaphylaxis scenario, management of an anesthetized patient developing severe cardiac arrhythmias can be practiced with the help of high fidelity simulator. Low fidelity simulator helps medical practitioner master individual tasks and smaller key concepts, while high fidelity simulator emphasizes realistic situation and puts more stress and pressure on practitioners. So these are the pictures of task trainer or low fidelity simulator. This is pediatric airway station on which we can practice bag mask ventilation, intubation, even umbilical vein catheterization, cardiopulmonary resuscitation. Another is IV access arm, where we can practice getting IV access, then IV fluid transfusion, blood transfusion like scenarios. This is lumbar puncture task trainer on which we can practice spinal and epidural anesthesia. This is a central venous cannulation task trainer where central venous cannulation can be practiced. With the help of pulse bulb, we are able to create a palpable pulse so that the relation of the vein and the artery can be understood. This is the whole body mannequin of nursing Annie, on which about 10 to 15 skills can be practiced, like eye care, anterior nasal packing, emergency cricothyrotomy, tracheostomy, putting intercostal chest drain, IV access, intramuscular injection, peritoneal lavage, bladder catheterization, handling wounds, care of ulcers, all these techniques, cardiopulmonary resuscitation, and in the sitting position, we can practice spinal and epidural anesthesia. This is a adult airway management trainer on which we can practice. It mimics exact anatomy of the live human patient. So we can practice oral and nasal intubation, bag mask ventilation. We can create scenarios like esophageal intubation where stomach inflation is possible. Then we can practice cricoid pressure. All these scenarios can be practiced with the help of adult airway management trainer. When the simple low fidelity task trainers are combined with the simple feedback device or SimPad, it increases learning accuracy. So it is a small video where a pediatric task trainer is attached to the SimPad. SimPad is a feedback device which gives us idea about the accuracy, about rate and depth of chest compression. So here we can see there is a green light which shows that rate and depth of chest compression is accurate. When anything goes wrong, it will show red light. So the learning experience can be improved with such simple devices. Coming to the standardized patient, this is a human-based simulation method. So what is a standardized patient? Standardized patients are actors trained to reliably role play. So in the photo, you can see this is our OT technician who is trained in creating some case scenarios. So here he is acting like a malignant hypothermia susceptible patient, and the anesthetist is practicing history taking of malignant hypothermia susceptible patients. Which skills can be taught? So pre-anesthesia checkup, communication skills can be improved. Then skills like taking informed consent, taking high-risk informed consent, explaining bad news or declaration of death can be practiced with the help of standardized patient. So what are the drawbacks? We can't practice invasive procedure. The advantage of standardized patient is the standardized patients are available whenever and wherever required and are trained to portray a specific case accurately, repeatedly, and in a consistent way. So there is uniformity when we learn on a standardized patient. This is a hybrid simulation. As we can see, there is one patient actor who is wearing a task trainer. So what do we mean by hybrid simulation? It is use of two or more simulation modalities in the same clinical scenario. It allows both procedural and communication skill training, bringing sense of realism to the training. That may not be possible by using only a human actor or only a low fidelity task trainer. So here we can see the picture of tracheostomy overlay system worn by the patient. Another picture is IV access arm, which can be worn by the actor patient, and we can create this blood transfusion scenario or adverse reaction because of blood transfusion. So here is the video which is showing the standardized patient is wearing tracheostomy overlay system. It has sensors. So if there is any mistake in conducting the tracheostomy tube suctioning, the vibrations are sent to the actor and actor acts like coughing or it shows discomfort. It is also used for the auscultation of different lung sounds like wheeze or any other crepitations. The scenarios which can be practiced are the artificial mucus plug can be inserted in the tracheostomy tube. So scenario like blockage of tracheostomy tube because of mucus plug can be practiced with the help of tracheostomy overlay system. In one paper, these two techniques were compared, that use of mannequin and tracheostomy overlay system for training the trainees. And the much more positive behavior was observed with the help of tracheostomy overlay system. Coming to another type of simulators, which are screen-based simulators. So these are screen-based simulator or computerized simulators we can say. So here there is case library which has different cases already fed to the simulator. It helps automatically to the trainees. There is automated debriefing and scoring, and automated case record is being done so that trainee can see his or her performance. So which scenarios can be practiced with the help of computer-based simulation? Advanced cardiac life support, pediatric advanced cardiac life support, critical care simulation, anesthesia simulation, obstetric simulation, all these can be practiced with high fidelity computer-based simulation. Here is the video which shows the task trainer is ultrasonography compatible and the trainee is practicing the cardiac ultrasonography, and this is a 4-chamber subcostal view, the cardiac ultrasonography. Coming to high fidelity simulators. The high fidelity simulator makes use of full body mannequin which behaves like real patient. The patient is able to breathe, peripheral and central pulses are palpable, it can produce pupillary reactions, cardiac rhythms are visible on the monitor, administration of medication or any intervention done by the participant produces physiologically appropriate response. So here in the picture, we can see the Simman 3G whole body high fidelity simulator, and another picture is high fidelity birthing simulator. So high fidelity simulator are interact with the learners. It teaches crisis management. It improves teamwork, and scenarios can be changed based on participants' intervention. So here is the video of high fidelity simulator and how the scenarios are created.
Carl. Code blue, room 3. Okay, everybody clear? Clear. Charging. Clear.
So we can see how beautifully the real life medical situations are created by high fidelity simulation. This is a high fidelity birthing simulator on which we can practice normal delivery, high risk deliveries of pre-eclampsia, eclampsia patients, scenarios like postpartum hemorrhage, cardiac arrhythmias, then techniques like intubation, cardiopulmonary resuscitation, spinal and epidural anesthesia, auscultation of heart and lung sounds can be practiced with this type of simulator. Coming to virtual reality, VR tools create immersive experience that place trainees into hyper-real scenarios. Trainees feel like as if they are really in the operating room or in the ICU where they are actually facing the clinical environment and they're working with a live patient. So in this video, you can see a trainee on the right side. He's wearing a headset and in his hands are the joysticks. So the body movement and hand movements of the trainee are actually transmitted into the virtual reality. The trainee is actually in a one small closed room, but he is feeling as if he's dealing with the real patient and he's standing in the operation theater. This is the scenario where he's practicing bag mask ventilation and intubation. So virtual reality gives a hyper real scenario of the clinical situation. As now we know what are the different types of simulation, I would like to introduce how we conduct simulation session in our institute. This is an outline plan of a session where the session is broken up into different steps for the easy of accuracy of training and for the ease of assessment. This is the intubation checklist, and these are the stepwise manner in which the trainee is assessed. It starts with the assessment of patient and airway and ends with the securing endotracheal tube. And we can see whether the trainee is getting improved in first attempt, second attempt, or any further attempts are required. So we practice repeated training session of bag mask ventilation and intubation. These are interns practicing bag mask ventilation and intubation on adult airway task trainer. These are our faculties who are practicing in our simulation lab, and they try to create different clinical scenarios which we conduct in the operation theater, OPD, or even wards. So we conduct different training session in our operation theater. And here I want to show you the video of one of the training session which is conducted by the faculty and residents inside operation theater.
This is the airway task trainer. Today we are going to practice on this how the intubation is done, how the patient is ventilated, and after the intubation we will see how the patient is put on ventilator. This is the airway anatomy. Once you introduce the laryngoscope and displace the tongue to the left side, we can see this omega shape epiglottis. We have to lift that. Once you lift that epiglottis, you can see the inverted V shape pearly white structure, that is vocal cord. This is how we can put the mask and ventilate the patient. With the help of video laryngoscope, we introduce the scope from the right side, displace the tongue cords. Epiglottis is lifted. With the help of endotracheal tube, we will intubate. See, that black line is going beyond the cords. Put the patient on ventilator. Tidal volume 5 to 8 ml per kg according to the patient weight, with the IE ratio of 1:2, frequency ranging from 4 to basal atelectasis in the patient. Both the lungs are getting ventilated properly. We can also create the scenarios like laryngospasm by blocking this tube. See, now the lungs are not getting ventilated. With the help of this task trainer, we can create multiple scenarios like this, and we can practice all these scenarios before giving anesthesia to the live patients.
So here, how we can create different scenarios with the help of just simple task trainer. So it's not necessary to have always high fidelity simulator to create real life scenarios which are life threatening inside the operation theater or anywhere inside the hospital. This is another scenario which we can create with a simple task trainer. We have filled the artificial stomach contents into the stomach, and by squeezing the contents of the stomach, we can create the scenario of regurgitation and aspiration. Here we can see the stomach contents are getting regurgitated. This is a scenario of regurgitation, and we can train or we get practice the proper suctioning technique and even rapid sequence induction with the help of this task trainer. Now, another practice which we do on a regular basis is giving case scenarios to the team of residents and faculties. And we practice these case scenarios inside the operation theater to train the faculties as well as resident in life-threatening scenarios. So here is one case we have practiced inside the OT. This is a 30-year-old male patient having abscess on the chest, posted for incision and drainage of abscess. Is a chronic smoker and there is no other comorbidity. After completing the checklist and after uneventful induction, this is what happens. So here is the checklist which is given to the assessor, and the assessor sees if the scenario is being conducted or any in a proper way or any steps are missing. So this is one of the case scenarios which is done in the ROT setup.
Sir, patient is anesthetized. Let's start with the procedure. Patient is not getting ventilated. Shraddha, turn off inhalational agent and give 100% oxygenation.
Sir, 100% oxygen started. Sir, I'm starting suction. Sir, there are no secretions.
Let me see once again that the patient is getting ventilated or not.
Sir,
Still patient is not getting ventilated. I am repositioning the patient and keeping the oropharyngeal airway. Let me check. Still patient is not getting ventilated.
Ma'am, there are no breath sounds.
There is no airway. I think it is laryngospasm. Please give 100% oxygen. Have you given? Yes. Now you can start with CPAP. Please close the valve. You start giving CPAP.
No ma'am, still
is there
patient.
Any improvement?
No ma'am, patient is not getting ventilated.
I think we will deepen the plane of anesthesia. Shraddha, please give propofol 0.5 milligram per kg IV.
Yes,
okay. Then we'll have to give scoline now. Shraddha, give 0.5 milligram per kg IV scoline.
Scoline.
Flush karo.
Flushed it? Okay. Yes, ma'am.
Yes ma'am, yes ma'am. Yes ma'am, patient is getting ventilated right now.
Right.
the saturation is also improving now.
Okay, now you please check the air entry again.
Yes, ma'am. Checking the air entry.
Yes. See, ventilate and see.
Yes ma'am.
And
So these are the different scenarios which we create in our OT setup, and routinely the faculties and residents are practicing with the help of low fidelity simulator. So here I would like to tell Medical Council of India has created a beautiful module of skill training. We all can read that module and practice simulation our day-to-day practice. These are few of the websites where different simulation scenarios are available, and how to create different simulation scenarios can be learned from these websites. So how simulation has helped me? The simulation has taught that there is no limit to what extent we can use simulation in our day-to-day practice, and it definitely improves the safety of the patient. So the take-home message is simulation is effective way to practice skills repeatedly and get expertise. It enhances confidence and ability of decision-making. It helps to improve coordination in teamwork. It prepares us for unexpected, uncommon situation in safe environment. The simulation scenarios can be practiced on daily basis even without high fidelity simulators. Thank you so much, and I hope this day-to-day practice simulation will help us in improvising patient safety and for improving our skills. Thank you so much.
Thank you, Dr. Savni, for taking us through that. All your videos were wonderful, and your take-home that we can use even the low fidelity simulator for our own learning purpose. And I invite the chairperson's comments, Dr. Sunita Sanklesha, please.
Yes. Tawni, it was indeed excellent presentation, and I'm very happy that what our department is doing, that you have shown to all SAMs. It's really very good, and we are really practicing all these scenarios, and that is how we are teaching our residents. But as Anita said, how this simulation can be used by private practitioners. So that is really very important. And I must say that simulation sounds, for private practitioners, how can we do this? We don't have simulators, and all these questions must be coming in their minds. But as she has rightly said, that all these case scenarios and mock drills we can definitely perform. See, if such a situation occurs like laryngospasm, or say someone is collapsing and all these things, one single anesthetist is there in OT, then how to tackle these situations? For these mock drills are really, really very important. And simulation is not about just procedural skills. It is about teamwork, communication. See, you must have seen that how that team leader was giving orders to the members of the team and how everyone was performing. Otherwise, tackling such critical situations becomes very difficult. So, simulation is not about only procedural skills, it is about communication skills, learning communication skills, and doing the task so easily, and you can become a team leader of that, and you can take charge of that situation and you can treat it. So it is very important, and I think for freelance anesthetist it is very important, because if they are practicing alone, they are alone in the theater and such situation occurs, then it becomes very difficult for them how to manage that patient, and it's a nightmare for a single anesthetist if such situation occurs, like laryngospasm, last, or cardiac arrest. So I would like to thank Anita for taking this topic. It's really, really very important. And while doing our CMEs and workshops, we can include such scenarios, and like teams like medical colleges can perform such situations in the workshops. And of course, she has already mentioned about debriefing and checklist, and we can perform such case scenarios, and our colleagues, freelance anesthetists, can really learn these tasks, and it's really very important. It's not necessary that you should have high fidelity simulator or task trainers and whatever she has shown, like task trainers or airway management trainers. It's not must, but even at least case scenarios we can perform and mock drills we can perform. So over to you, Anita, your expert comments on this.
Thank you very much, Sunita. Dr. Kalyani, are you there? I think we don't have her. Dr. Vaibhavi, do you want to give any comments here?
In fact, Savani has made my job very easy. So she has created a wonderful base for the further presentation. So now, with all the information of how simulation can help every anesthesiologist in private practice, I think the next session will be far more helpful to everyone, because now they will truly know the essence, because her explanation was brilliant. All aspects were covered. And please remember, simulation centers are not only for students. Even private practitioners can utilize the facility during workshops, during training programs. So you're all very welcome. Thank you.
Thank you very much. Just I want to add, it is for the information only. Long before 30 years back, when we are a PG student, that time these simulators were not available, and our teachers create the situation to teach us. Now it is very high, it is risky, I know, but at that time they created how to see the cyanosis. There was at that time there were no monitors also. Even pulse ox was not there. Only ECG machine was there, or ECG monitor was there, and at that time they create how to look for the cyanosis, and how to see for the bronchospasm and all that thing. So at that time they create the situation and teach us. Thank you very much. But it is high, it is risky, I know. It's not possible now.
even our teachers in Mumbai during our residency, they used to show us a total spinal, how total means doing a head low and showing total spinal and then to resuscitate the patient. But as sir said, it was really risky. And now we have higher end simulators and, many things. So even we are coming into the field, so we can definitely learn and spread this knowledge to everyone. Thank you. Thank you, dear Sauni.
Of course, we don't recommend doing these things.
Yes, not at all.
No, actually
But
not at all.
what we can do is, suppose you have a mannequin, a low fidelity mannequin, you can show a ECG strip showing that there's a ventricular fibrillation. So if when the trainees are taking necessary steps, suppose they do it correctly, then you can show that, okay, this rhythm has now become fibrillation, or it has reverted to a different type of rhythm. So you can show them different strips, and then you can, sort of take them through the case. So that type of a simple low fidelity case scenario can be, taught to trainees or to consultants. So let us move ahead, and Dr. Vaibhavi, I request you to please start with your presentation.
Yes, sure. Thank you so much. This is you could say a warm area, like, a SAMS symposium. And this is the first time I'm coming here, but I don't feel like it is the first time. Anita madam had made me so much comfortable that you just come, don't worry, we'll help you. And all the technicalities were taken care. So thank you, SAMS, for inviting me and Savani here. We both had a great time. And I hope that after our session is done, there's a huge learning for everyone and an encouragement to use simulation to learn. So I'm going to begin the next session, which is actually a simulated case scenario virtually for difficult airway. Okay, so just give me a moment to share my screen. Okay. Can you all see my screen here?
Yeah, but there are gray patches. Yeah.
Yes, madam. We can see.
Now
Yes.
we can? Okay, great.
Yeah, yeah.
So today we are going to have an experience of a virtual simulation of difficult airway. For this, I would request all the participants and faculty also to scan the QR code which you see on the screen with another device if possible, or with the same phone that you have joined the Zoom link. It is possible either to toggle between Zoom and the Mentimeter, or you could use another device. That's also perfectly fine. If you can't scan, then on top, you can go to menti.com. You can see at the top that there is a website mentioned, and use the numeric code for entering this Menti. So as I can see, there is one person who has entered. I request as many people to enter this menti.com using the scan.
Madam, vote code is 35632155, right?
Yes, 35632155. As soon as you enter, you will see the screen that I'm showing here on the laptop.
I'm not getting the page of code.
Sorry?
I'm not getting the page of code, entering the code.
Or you can go to Google and type this website and enter with the numeric code. Either you scan or you
scan the QR.
Scanning the QR is easier.
Yes, scan the
It will
QR
just take
with your camera.
So we can scan with Google Lens. The website will, the link will come and we have to click on that.
Vaibhavi, I'm seeing you are all set. So does that mean that I have entered that.
Yes, somebody is typing a hello also on the screen, if you can see on the right. So there are many people who have entered. Yeah, and somebody is writing on the screen also, Neha. Okay, I'm going to give another 10 seconds for this. Can't get user code. There is no user code. It is just scanning, and whatever PPT slide that I'm showing you will be seen there too. Okay. So using this code, I would request all of you to answer this question. How many of us have come across an unanticipated difficult airway in our practice? I can see 36 people who are there right now and they are voting. Okay, so okay, 22 of them have voted. You could see 50-50. Okay, so some of them have come across a difficult airway many a times. Some of them have come across, but not so much, very rarely. And there are some special people, 4%, who have not come across yet. Okay, but that day could be tomorrow also. Okay, in our practice. So, yes, these are the people we would like you to go through this whole program to visualize what it could be. Okay, so, thank you everyone for voting. I'm going to go to the next slide, which is an unanticipated difficult airway management. The goal of our simulation session is to have an experience virtually of an unanticipated difficult airway. So we have a case here, which is 35-year-old male patient, Rakesh, who is weighing 60 kilos and is posted for an elective laparoscopic appendicectomy. PAC is done and the patient is ASA1, well fasted, no respiratory symptoms, no comorbidities. Airway examinations suggest no difficulty. Okay, investigations are all within normal limits. Informed consent has been taken. I think the day is beautiful. You know, you have a patient like this, which is ASA1, and absolutely no problem. You feel, oh, the day is going to start really well. But what really happens is what we are going to see. The anesthetist enters the operating room. The airway trolley, intubation trolley is prepared. Considering that this airway looks good, the patient is ASA1, it's a wonderful day. The OT technician has kept everything ready. You are happy. Okay, you attach the monitor. Okay, you set the patient, make them comfortable, nice and warm. The OT is ready, surgeons are there, timeout is done. Surgical safety checklist is done. The vitals are connected, measured. Patient is absolutely stable. Okay, I think this is like a ideal day, you know, to start your first case on the list. Pre-oxygenation is begun and the patient is pre-oxygenated for full 3 minutes till the end tidal oxygen is above 90%. Okay, so we are all set to begin. So now let's look at what happens. Okay, I would like all of you to see these videos because they are simulated. Of course, there is a patient, but then we have taken due consent and we use these videos for educational purpose only.
So we have done the PAC, food checklist is done, monitor is on and all the parameters are normal. Oxygen is on and I'm pre-oxygenating now. So could you take some nice big breath for us, in and out? And could you start induction phase first?
Inspiration first. Start inspiration.
Yeah. So breathe normally. Start inhalation.
Starting with the proportion.
जो पेन हे औषध कधी कधी थोडंसं दुखतं त्याच्याकडे लक्ष देऊ नका घ्या आणि सोडा तुमच्या आणि व्यवस्थित काळजी घ्या Just going to hold this mask bit tight on your face.
Slowly.
Thank you.
Slowly.
I can't see anything. It looks like format layer in grade 4.
Okay, so did you hear the last sentence that the anesthesiologist said? She said, it is Cormac-Lehan 4. Okay, so whenever you hear this word, how do you feel at this point of time when you hear? Scary, yes. Terrified, I agree. Okay, it could be a moment of, okay, this was a great day to begin an ASA1 patient, and suddenly this is the word that you hear. Okay, panicked, yes. Stressed, okay. So there is going to be some searching for, advanced equipment. So this is a point where we are going to be in a situation of crisis. Terrible, looking for help, absolutely agreed. So what happens next, we are going to look at. So let's look at how was this patient managed. Please do remember, this is a simulated video. We wanted to create a video to help you imagine the situation. Okay, so this is not real.
2, 1. I can't see anything. Can't even see epiglottis. It's really difficult. Maybe. Give it to you?
Yeah.
Maybe. Okay. Yeah. No, it is you too.
No chest like that.
No chest right. No, it is you too. How come it is?
No,
I thought
don't
it's
think
it.
this one is.
Okay. Let's do this again.
We'll take it out.
Okay. Should be. Again, I can't see much actually. Really difficult. Can't even see epiglottis, not even a tip of epiglottis. Just pass me the tube. See whether I this time.
Attending ventilation.
No chest rise and no ETCO2.
I don't think it's easy.
I thought it's in. Saturation is going down. Let me just, I should be able to get it in.
Call for help.
I should be able to get it in.
You want to oxygenate patient or put in mass ventilation or something like that?
Let's do mass ventilation.
Yes.
Okay, just ventilate.
Yeah.
Just ventilate.
Trying to ventilate.
Yeah, ventilate. Oh no. Okay. Saturation is low.
No.
Are you ventilating hard?
Yeah, I'm ventilating hard.
Just call somebody. If saturation is 67.
Please get some help.
Please call
Patient
somebody.
is desaturating.
Just go and shout for some help.
Please get some help. He's desaturating.
Okay, so our situation is the first attempt of intubation failed, even a repeat attempt has failed. How do you feel at this point of time? Imagine you're there in that OT and you're the anesthetist. How does that make you feel? Call for help? Yes, scary. Oxygenation was not happening, and that is really a concern. Apprehensive. I think just hearing that hypoxia sound itself puts us into a tachycardia, right? So our coronaries have gone for a toss. And this is the time there where we actually cognitively, truly, feel that I can't think, or we might start thinking of a lot of actions, but in panic, we may not take the right decisions. Okay, yes. So what we are going to do is we are going to learn some mindfulness, a quick mindfulness trick that we have, and we teach our students to cognitively reset ourselves. Okay, so there are some resetting, exercises. Yes, this was a poor preparation because it is a simulated video. We wanted you to experience that. It's not a true situation. But how about if we start getting panicking and we don't think of the correct decisions to take? It could be a problem. So there is a small exercise. Just do it on a regular basis and you'll see the benefit. The first question you have to ask yourself is, what am I feeling? Okay. And you say, I am panicking. Okay. The second thing that you tell yourself, it's okay to panic. This is a situation where, panic is normal. Okay, so you validate your emotion for a while, like few seconds it takes. And the third thing is you have to tell yourself, in spite of this panic, what would I like to do for this patient? I think this is a 3-step cognitive behavioral method in which we can actually come out of a mental block or a cognitive overload. Try these things, 3 questions, and it will help you during such crisis. So there is a cognitive aid which is available, and we have DAS guidelines. We also have the IDA guidelines, the Indian guidelines, All India Difficult Airway Algorithm, which is easily available, and if is in the OT, it will be amazing. And like Dr. Savani mentioned, to actually make your team go through a mock drill using this guideline could actually practice and prepare our teams to support us when we are in this crisis. So what does this guideline say, which is of 2016? That whenever there is an unanticipated difficult tracheal intubation in adults, step 1 is, of course, laryngoscopy. But if it fails, the first attempt fails, we still have 2 more attempts. And the last attempt is by an expert, by a senior anesthesiologist. There are multiple steps like plan A, plan B, plan C, and plan D. Okay. What we are going to do today is we are going to see videos of every step and how we can navigate. Okay. So let's look at the things that have happened further.
I can't see anything. This looks like Cormac-Lehane grade 4. Let me just try. Maybe it's in. Let's see whether we get it in. Okay. Just ventilate. There is no chest rise. No EtCO2. Okay, so this is not in. Right. Do you want to call some help? And I'm going to do bag mask and give me 15 liters oxygen. I had asked Dr. Palade to be around.
Okay.
So just see whether Dr. Palade is next door.
Dr. Palade, can you come please?
Okay, so let's put this oxygen on.
Hey, what happened?
He is a young chap who is having lap appendix.
Okay.
And it was unanticipated grade 4 intubation.
Grade 4 it is?
Yeah.
Okay.
I couldn't see anything. I tried one attempt with normal grade.
Okay.
And it wasn't in. So one failed attempt.
Yeah.
I'm able to
ventilation is good.
ventilate.
Yeah.
I put 15 liters oxygen mask with nasal prong.
Okay.
And I tried with normal grade. So now I'm planning to use video laryngoscope. We got, I haven't used it, but I'll see.
Okay.
And we got stillate and small size tube.
Yeah.
So we got,
Fine.
so saturation is okay.
Yeah.
So and ventilation is fine. So should we try with video laryngoscope now?
Yeah.
Yeah. So, okay. Let's see. Give me bougie, please.
Let me know if you need some pressure.
This is first time I'm using it. I'm not really sure how it works. Maybe it looks like it's in. Okay, let's railroad this. Okay.
Just inflate it up, please.
Okay. No chest rise, no EtCO2, saturation is 94. No, I don't think it's in. No.
Okay.
Let's take it off.
Fine.
Let's balance
mask
mask.
ventilation again. Fine.
Okay.
Okay.
Right. So
Yeah.
I'm able to ventilate.
That's fine.
Saturation
Yeah, it's getting up.
picked up.
Fine.
Right. So what's
next?
I got McCoy's here.
Okay, I think you can use that actually.
Okay.
Yeah.
And then there is a stillated tube.
Okay.
So McCoy is stillated
Okay.
tube.
You are happy with the position?
Position I have optimized it.
Okay.
Here.
Fine.
Do you want to try? I mean,
I think okay. You one more attempt, I think.
Okay.
that's
So we are
fine.
able to
Proceed.
ventilate, so that's good. Saturation is 98. Should we try?
Yeah, I think.
Yeah. So stillated tube. Can you put the stillated tube ready?
Yes.
Keep the stillated tube ready. I'll ventilate him. Once you are ready, let me know.
Stillated tube ready.
Okay. Okay. Let's see. This is great. Size 4 McCoy.
Okay.
So hopefully
Let me know.
I can just see. Can't see much. Lot of pressure.
Yeah,
Lot of
yeah.
pressure.
It's fine.
I can't see much really. But I can see just about tip of epiglottis.
Yeah, I can feel something. Yeah.
Good?
I think so. Yeah.
Very good. Okay. Let's see.
Okay. Just inflate it, please. Okay.
Okay. Yeah.
Oh, yeah.
Oh gosh. Okay. That's fine.
Yeah.
So he's got chest rise, saturation 98. Is it
Yes,
EtCO2?
we are getting EtCO2 there.
Okay, that's good.
Yeah.
Okay, so yeah,
Perfect.
so that's good. Thank you very much. Thank you, Dr.
Thank you most. Thanks.
Okay, so now that you saw a video which demonstrated the plan A, okay, so what all things went well as compared to the first video we saw where there was a lot of panic, there was no oxygenation. And in this case, could you all comment, everyone, through the Mentimeter, what all went well? 50? What is 50? Okay, can you all comment what all went well? The call for help was given early, yes. The help arrived. It was right there because it was pre-informed. I may call for help. A use of a video laryngoscope. Okay, and yes, that's a question. How many of us as private practitioners do have a video laryngoscope? Okay. Yes, ventilation was maintained throughout by bag mask. Problem is defined, yes. Oxygenation was maintained throughout, and mask ventilation, fortunately, was possible throughout. Yes. Change of equipments was planned. Okay. There was a McCoy used. There was a stillated tube used. Yes, oxygenation at all times was looked after and maintained. Change of position was planned. The communication was robust. Yes. Excellent. So I think with the extra help, the confidence of the primary anesthetist also was good. There was no spiral of confidence spiraling down. The teamwork also seemed very smooth here. Excellent. So as we see, if we have a failed intubation, to optimize the intubation attempts after that, the 2 attempts, even asking the senior anesthesiologist, would you like to intubate, was also done. So I think this is the first learning that we take. But in this stage, as a private practitioner working in your own respective hospitals, I want you to think what could be the challenges in this stage in your setup. Okay, this is a completely anonymous platform. Nobody knows what you're typing, which hospital, so no names. But then, can we suggest what are the challenges you think could be there in your hospital at this stage of first intubation failed attempt? Availability of video laryngoscope, no help immediately. Okay, yes. Expertise may not be available. Okay, qualified and trained assistants may not be available. Okay, anything else? And I think that's how Dr. Savani is trying to, train our assistants or train, in fact, our, people who can help us during this crisis. Even for calling for help, can we arrange, do we have a system in place that if ever I have a problem, is there somebody else we can call for? For example, is there a possible that we can call somebody from the ICU, a 2-bedded ICU also, but there would be somebody who is in the ICU. There could be somebody in the ER. There could be another freelancing anesthesiologist. If you call them, they could be passing by and say, okay, I'm free, I can come. Yes. Keeping a McCoy blade instead of a video laryngoscope also is something that we can carry in our bag. Right? I think the surgeon should also be there. And if you really ask the surgeon that can you help, they know the anatomy so well. And actually speaking, if we involve them in the training, they could be also of help. Okay. Single-handed being in private practice is definitely a problem. But can we prepare for it by creating this support system of intensivists, support system of ER, preparing them for such an eventuality in future, a jet ventilation if it is there. Okay, so as the algorithm progresses, we will come to the advanced stages. But right now, thinking of a stillated tube, thinking of a McCoy blade, positioning the patient, all these things, calling for possible help that can come, and especially if we have trained them beforehand. Okay, so teamwork, like somebody has mentioned, lack of teamwork practices. Teamwork can't happen during crisis if we haven't proactively developed our teams in different hospitals. So freelancing, there is a more added responsibility. If we go to 4 hospitals, all 4 hospitals, how do we help develop their teams? Because ultimately it is us who's going to benefit. Thank you for all these things, for all the suggestions. Now we will go to the next aspect, is just go through exactly what the video, the primary anesthetist in the video did was plan A. She continued nasal oxygen flow. As you could see, she put nasal prongs. She gave 2 attempts, but made sure that bag mask was done between the 2 attempts and the SpO2 was brought up. Optimize the position. Somebody asked, like, can I give a burp maneuver, an external laryngeal manipulation? Do I need a bougie? Proactively asking for a bougie, proactively asking for a stillet. Okay. changing the device based on availability, and also the depth of anesthesia, just thinking whether it is enough muscle relaxation. So if it succeeds, yes, we get a good capnograph and we resume with the surgery. But what if the plan A fails? Okay, so we are going to see what if plan A fails. One, start.
So no chest rise, no ETCO2.
Okay.
This
Think
is
it's
third
more than,
attempt
yeah,
that I've not
okay.
got the test tube in.
Okay, we'll do back mask
Back mask,
ventilation.
yeah.
Fine.
Yeah. So,
Okay, just
so
back
he's
mask
got
ventilation.
15 liters oxygen
Yeah.
on with
Yeah.
nasal
Good
pump.
chest
They are
rise.
able to ventilate.
Yeah.
There is some ETCO2, so that's good. Now what can we do? So
I think we are on the step 2 of the algorithm now.
Yeah.
Where we should go for the supraglottic airways.
Okay, that's
We
right.
have the elements with us.
We have IGEL and we
Okay.
have Supreme.
Okay.
Yeah.
You want to go ahead with IGEL?
IGEL, yeah, I'll go with
Just
IGEL.
get ready with the IGEL. Okay.
Yeah.
Put some gel there. Yeah.
Okay.
Good, that is getting
Yeah,
nicely
it's getting
ventilated.
ventilated.
Saturation is fine. I will just
Yeah.
give on the anesthesia.
Yeah, okay.
You ventilate. I will
Yeah.
do some.
So once you,
then
yeah,
propofol.
you given some anesthetic, yeah, that's fine. Shall we try?
Yeah.
Okay. Okay. Right. Let's get
Okay,
this
just
in.
connect it.
Yeah. And let's see whether this works.
Okay.
Okay. You ventilate it?
No.
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 Okay.
Just
So no
No,
ETCO2, no chest rise. So shall we get
Yeah, I think-
this out?
Yeah, get it out.
Ventilate him.
Yeah, again ventilate.
Okay.
Everything is fine.
Okay. So ventilation
Yeah,
is
ventilation
good.
is good. Getting ventilated. Yeah.
Is there ETCO2? Yeah, there is
Okay.
ETCO2.
What options we have now?
We have another
Yeah, you
LNA.
want to try? Maximum we can do 2 attempts.
So we'll do
Yeah,
Supreme.
Yeah.
We got
I think
Supreme.
1 attempt with the LNA again.
Yeah, yeah.
This is the
Okay.
second
Supreme.
generation.
Keep Supreme ready. So I'm ventilating. Okay. So saturation is maintained.
Yeah, we'll need this one. Fine.
Okay.
Okay.
Right. Let's see.
Okay.
Okay. Let's see whether this works.
Yeah.
Just a minute.
Yeah.
Okay. Let's see.
Ventilating.
Yeah.
Oh yes.
Yeah.
Yes.
Yeah.
Yeah.
Okay, that's good. There is
Yeah.
some ETCO2.
Yes. We are getting
Okay.
this
Okay. So that's fine.
Yeah.
Oh.
There's some
Okay, so
distinction.
keep
So you want to put the
Rice cube, yeah.
Just get the rice
Give
cube.
me rice cube.
Yeah.
And what do we do now? Because
This is what lap appendix is,
yeah,
right?
yeah.
Okay. So you want to continue with the 11? Is that still good and?
I'm not very happy with element, though it's good at the
Yeah,
moment.
yeah.
But I think I'm not sure
It's
how
very
it's going to
difficult
behave.
information in case you lose the airway in between.
Yeah,
Just as
and this
issue.
is lap appendix. So,
Okay,
I
so-
would like to do fiber optic and then see whether I can get a definitive airway.
You want to do fiber optic through LNA or?
That is one option.
Yeah.
Or otherwise, safest option is we can wake him up because
Yeah.
we can afford to wake him up
Yeah.
and do a big fiber
Yeah.
optic.
We can discuss with the surgeon actually.
Yeah.
We'll
Let's
wake him
do
up.
that. So
Yeah.
we'll wake him up.
We'll wake him up
Yeah.
and we can regroup with better equipments and all that, and probably we'll go ahead with the other fiber optic.
Yeah.
Okay.
Yeah, I think
Or
that's-
you can discuss with the surgeon if he wants to do open surgery and you can get away with the regional.
That
That
is
is also
also
another
okay.
option.
That is also
Yeah.
right. Yeah.
I think
Yeah.
so.
So at the moment we are okay. We are,
Yeah.
so he's safe. He's
Okay.
oxygenating
Yeah.
well.
Yeah.
So we stop anesthetic
Yeah.
and let's wake him up.
Yeah.
And then
fine.
see where we go.
That's good. Okay, fine.
Okay, so now we saw that the step 1 failed, that is plan A failed, and the team moved to plan B. Okay, so can you tell me what all went well in plan B? That is use of supraglottic airways. Yes, LMA was inserted, LMA was available. There were an option of LMA, that is 2 types of LMAs were available. Plan B, well discussed. Okay. They did think of should they go ahead with LMA and continue with the surgery, or what should we do? Was an option. They wanted to discuss it with the surgeon also. They did follow the algorithm. Okay. Being 2 anesthetists being there has really helped. I agree. But sometimes when we are single-handed and when the bag mask is possible and SpO2 can be brought up, oxygenation is okay. It does give us time to think about the algorithm. There is a plan to awaken the patient also. Okay. If the surgery needs to happen, in that case, if a definitive airway needs to be done, we can awake the patient and either choose to do a fiber optic or conduct this patient on in regional. But regional is not something that is an answer because we still need an airway plan. Yes, supraglottic airway, EtCO2 was available and it was used at all times. They maintained oxygenation come what may. Absolutely. They tried two types of LMAs because one, if it doesn't fit, the size or the type of LMA can be changed. Okay. So we did see something well. Now, again, we go to the next question that what could be the challenges for private practitioners in their respective setting in this particular plan B? Okay, everybody needs to think what could be the challenges in this plan B? Availability of supraglottic device. Can it be made available? Availability, yes. Can it be made available? Okay, how many of us, we have to think, how many of us do really carry an LMA, a second generation LMA with us in our bag? Is there a need for emergency? If it comes to this stage of putting an LMA, and if we rely only on the hospital, can we have our own, either as a group of practicing anesthesiologists or as a single individual practitioner or as a hospital? Staff not trained and unable to understand the severity. I think here you really feel that team training, is going to really help. I think it is extremely crucial, especially when we are alone, that, we need our teams to be really robust. Somebody has mentioned that they have all the types of LMAs. Okay, I think this is brilliant investment for the safety of our patient, at the same time, our own safety too. If a proper fit of LMA is not achieved, yes, there could be a challenge in this case. In that case, the size of the LMA or the type of LMA needs to be reconsidered. Okay, there could be challenges there, I agree. But then, yes, at least oxygenation can go through. Okay, so we must train for FONA. We are coming at the plan D soon. Okay, so there's somebody who is wanting to fast forward, but right now giving it a try in the algorithm is important. Okay, because oxygenation has not dropped yet. Okay, so yes, there might be a possibility, but we'll see how and when do we go for FONA. Okay, so let's go to see how did they manage the plan B. Yes, they used a second generation supraglottic device. There were 2 attempts given. At all times, the SpO2 was maintained by bag mask in between and maintaining it above 95%. Okay, they did think of changing the type of LMA or the size of LMA. Okay, I think at this point when they succeeded, they thought of multiple options that are given in this algorithm. One, should we continue with the supraglottic device? Is it safe? Can we talk to the surgeon? Can we intubate through the supraglottic device? There are intubating LMAs which are available. But yes, they are expensive, but can a group have that, if time comes? Tracheostomy, if the surgeon is comfortable or if we are comfortable, we can go ahead with FONA. But waking up the patient is also an option and considering to buy some time and get some help to go ahead. So now there are some few photos, but of course they are very limited. There's an iGel, there's a Supreme LMA, there is a first generation LMA. There are many more intubating LMAs, fast track, pro seals. I think LMAs have really, developed themselves. There's a gastro LMA for endoscopies. I guess LMAs are our best friend, in rescue oxygenation. So now let's see what happens if the plan B also fails. That means LMAs also don't work. So let's see what we can do. Start.
Okay, I'm ventilating. I don't see any chest rise.
No chest rise
No,
there.
it is here too. Right, so this is our second LMA attempt.
Just back mask
So
ventilation.
take it off.
Yeah, just take it off.
Yeah, I'll ventilate him with bag mask.
I think where do we stand now?
Yeah.
Yes, it's getting ventilated.
Saturation is hopefully will pick up.
But we have already exhausted almost. We are on the step 3 of the airway algorithm
We
now.
have had multiple attempts.
Yeah. You want to put, get comfortable with the airway there?
Yeah, what I'll do
Just
is
put the oral airway, and if needed nasal airway as well, you can get. Just get that nasal airway. Yeah, I see that.
This is saturation dropping.
Yeah.
Okay, let's see. Let's see that the ventilation is improving.
We are getting saturation is getting.
Not really. I'm not really happy with this ventilation. Don't think that's
I think we have done so many attempts, so there must be edema.
Okay. Yeah, so
I'll just give some.
Front of neck access. Should we get?
I think we should go. Just get ready with the Portex Cuff 6 number tube. Yes. Okay, and Scalpel 10 number blade. Yes. And get one bougie. Yes. Okay, we'll go ahead with the front of neck access. Okay. Yeah.
I think that's yeah.
Okay. I think at this stage, when this is the stage where we have lost the bag mask ventilation, oxygenation is not possible with the rescue bag mask, which is the plan C. How does that make you feel? Just imagine yourself in this situation. What does that make you feel? Panic. Absolutely anxious. Okay, the anxiety is at the peak because now we have lost the bag mask ventilation. Frightened. Okay, imagine at this stage when we are feeling all these feelings and we are still wanting to take the correct decisions. I think this is where we really need to be, as calm as possible, and hence these exercises are important for us to be cognitively resetting ourselves. Okay. In the plan C, okay, where they were trying to do rescue bag mask because LMAs had failed, intubation has failed, what all things they did do well in this rescue bag mask plan C? They decided to go for FONA. They used the oropharyngeal airway, yes. They decided to go for FONA when the bag mask was not possible. Okay. Till oxygenation was there, they were okay. But as soon as oxygenation was not happening, they just decided to go for FONA. Quick steps taken. If you remember, they told the technician, anesthesia technician, that keep only 3 things ready for FONA. 1, a 6-number Portex cuff tube, a bougie, and a scalpel, a surgical blade. Okay, 3 things only are required for FONA. Okay. Early declaration of failure is important. What if at this stage they would have attempted an intubation again? What if at this failed stage of oxygenation they would have attempted an LMA again? Okay, so they are going back in the algorithm, but all those things have been declared failed before this. Okay, what happens here is we are actually losing time, and precious brain neurons are the time is ticking for them with hypoxia. Okay. Yes, why both oral and nasal? I think it could be even just one. Yes, it's a good point that you have brought in. It could be just one, oral or nasal. Yes, they were confused, and dilemma is there. In spite of this being a recorded video, there is some confusion you still see. Okay, and that's normal. That's absolutely normal. And that's what we are going to learn, that it is possible to happen. Okay. All right, we are going to go to the next. Just imagine again yourself in your own private practice, in your own OT when you're alone. And if you come at this juncture of plan C and you're doing a rescue bag mask ventilation, what could be the challenges at this stage? Never tried it before. Okay. Never tried the FONA, you mean, right? I don't know what is never tried. It means the bag mask or rescue bag mask. Okay. Untrained helping staff, lack of equipment. It's just 3 equipments you require for FONA. A 6-number endotracheal tube cuffed, bougie, and a surgical blade. I think we just need 3. So think of equipment. It could be in your bag. It could be in the OT because these 3 things we can also easily keep with us. Anatomical variation in tracheal position, especially if it's a difficult airway, anticipated difficult airway, actually marking the position of cricothyroid membrane is a routine practice that we are going to intubate and we are going to give it a try to secure the airway supraglottically. But then if I can't, the cricothyroid membrane is marked. Okay. Never practiced before, it's okay. Simulation gives you this opportunity to practice. And there is possible that you can do that, which I'm going to show you. Okay. Needle cricothyroidotomy. Please do remember, needle cricothyroidotomy is also one probability, but then to ventilate from a small needle using an umbu is near impossible because chances of barotrauma and stacking of breaths can happen when you try and ventilate from a small 16-gauge needle. We need a jet ventilation to actually ventilate from a small needle. Secretions in the airway, previous attempts might have caused trauma and bleeding. So as you see, the more attempts we have at intubation and LMA, the further steps of rescue bag marks and are going to be difficult, and hence limiting the attempts of intubation to 3, limiting the attempts of LMA to 2 is extremely important so that we know that we are not damaging the airway. Jet ventilation may be available or may not be available. That is important because we need to ventilate from the small needle if we do a cricothyroidotomy. CO2 retention. Absolutely. Somebody has brought in a very good point that we are only looking at oxygenation. Yes, but how about this patient's CO2? It could have gone very high up because ventilation was not possible. And hence this pH of, if you do an ABG for such a patient, the pH could be really dropping. So this patient could have metabolic acid, respiratory acidosis first, which will probably affect the drugs that we are giving. Okay. And more so, if this patient is full stomach, we are going to feel the risk of pulmonary aspiration. There is a vent train device, yes. We can take the help of surgeons for tracheostomy, but remember, formal surgical tracheostomy takes 15 minutes in trained hands. Okay, but a laparoscopic surgeon who has probably not done a tracheostomy may not be able to do this in the time that we want to save the brain. Within 5 minutes, it's not possible. So, emergency surgical cricothyroidotomy is a quick life-saving procedure, which I'm going to show you in the next video. I think there is a task for all of you private anesthesiologists. Please talk to your surgeon and ask them, do you know tracheostomy? And most of you might get an answer which is no. Okay, so that can be quite scary. So it's good that we learn as well. Okay, so let's go to the next step of this is what they actually did in the rescue face mask. They continued oxygenation, umbu bag. They use optimal technique of oral airway or a nasal airway. See, in this case, a neuromuscular blockade ensured. That means it is quite risky. It's a double-edged sword to give a neuromuscular blockade at this stage. Okay, but with sugammadex coming into play now, and sugammadex is available widely. I hope the private practitioners also have sugammadex to immediately reverse any neuromuscular blockade of a patient who is in CICO. Okay, cannot intubate, cannot oxygenate situation. So in this case, we can wake the patient up if we can reverse the neuromuscular blockade and the propofol that we are giving him. Okay. The next is what is the next step you would like to take in this situation? So some of you have already mentioned as FONA. Okay. Any other thing that you would like to do? I think the video itself has given you a shock. Come on, type please. Okay, HFNO, we can try. Okay, 1, we can awaken the patient by reversing the neuromuscular blockade using Sugamadex. Bag mask ventilation to be continued at all times. This is what we will try. Okay, what if they don't work? Okay. Any more steps that you would like to take? I think in the previous comment, somebody had mentioned about rigid bronchoscope also. A rigid bronchoscopy is available with ENT surgeons, and an attempt with that is also something that can be tried. But yes, supraglottically, I think the trauma, the bleed could make it challenging for us to intubate. Okay, so please remember that here, front of neck access becomes crucial, the timing to take the decision. So hypoxia should not linger for long, and we need to take the decisions of FONA at the earliest. But for that, we need to know how to do front of neck access. So I would like to ask all of you, how many of us have ever done front of neck access? Okay, never. Even me, in my practice, I had never done front of neck access. So I agree with this one person who has given me the answer. Okay. There is somebody who is saying 38% yes. Okay, really happy to see this. Some people are saying never. It's okay. Yes. Very good. So I think there is some amount of, awareness that front of neck has been seen, has been practiced either in real life or in simulation. Either ways is okay, because having a kind of a understanding and knowing how this procedure works will actually help us take the decisions early in a real patient, in a real crisis. So let's look at how to go about putting a front of neck access. Start.
So you continue to bag mask and 15 liters of oxygen with nasal prongs is on. I'm going to do this laryngeal handshake and identify the cricothyroid membrane, which is right underneath my finger. I got scalpel blade and a size 6 tube and a bougie ready. So I'm going to take a vertical stab and then rotate it 90 degree. Yeah. And then could you pass the bougie?
Yeah, I will pass it.
Yeah.
Okay, it's going in.
Is it going in? Shall I take the scalpel off?
Going to posterior.
Going through the scalpel. See whether we can do.
I'm trying to just hold it.
Okay.
You have to use 360 degrees rotating.
You're going to get it in here?
Yeah. Just get it out.
Okay, I've got the tube.
Try to ventilate here.
Okay.
Just inflate the softly.
Yeah, we can see the lungs going up and down.
Yeah.
And EtCO2 is there, so that's good. At least we got the tube in now. Yeah? Okay.
Okay, so Now that you saw that a front of neck access was done and using 3 things only, what all things that went well in this video? In this plan D? Good communication, well-trained anesthetist and assistant. Yes. Ventilation was done throughout. So bag mask was not stopped. Okay. They were calm and doing their job. Availability of these instruments. Okay. A good teamwork. The procedure FONA went uneventful. Okay. Identify the cricothyroid membrane. Training for FONA, a simple mannequin can actually help us practice this procedure. The steps were followed. Absolutely. So if you see, it is not a difficult procedure. We do far more difficult procedures like central line and so many things. It is not difficult. The only thing is it is done at such a crucial, cognitively overloaded moment that we feel, oh my God. But frankly, if you see the technical skill required for it is very simple. Okay. And that can be achieved through practicing in simulation. Okay. All right. So now I want you to think again in terms of your private practice. If ever you come to this stage of doing FONA, what do you think are the challenges that may come? Okay. Which today we will try and troubleshoot and see how best we can overcome them. Not trained in FONA? This is a problem. Tomorrow, all the simulation centers in Pune, Pimpri Chinchwad, they are open for all of you. Please do come access. In fact, let us know if you need something. We can plan a training. All of us are here. Okay. Unfamiliarity. Bougie not getting threaded. Yes, it is possible that the bougie doesn't thread well. Okay. Surgeons may not agree for the aggressive decision. We need to tell the surgeon that we need a patient alive and not a brain dead patient at the end. Okay. Sometimes the patients need to be, saved first. It's not the aggression. It is more about saving the patient. Lack of confidence, and absolutely FONA, if we have never done, we won't know. Okay. Yes, training of the anesthetist along with the team. Training should be done at regular intervals. Very important. It's important that we don't forget this procedure. So maybe once in 6 months, just go practice and come out. That's okay. Yes, there could be a thyroid in the middle, but we are not doing the procedure over the trachea. Please remember, cricothyroid membrane is generally free. This procedure is emergency surgical cricothyroidotomy. Okay, it's through the cricothyroid membrane and not through the isthmus of the thyroid. The isthmus is not present at the cricothyroid membrane. There is a possibility of bleed, yes, and hence we really need to make sure that the tube is in. It's a surgical procedure. In fact, your surgeon can really help you at this point of time. Okay. Right. Let's look at an ultrasound can be used to identify the cricothyroid membrane. It's fantastic. If you know ultrasound and it's available in your clinic and it's a difficult airway, you can just put a probe and find out where it is. Even clinically, all our PACs, how about not only assessing the patient's airway, the routine way, how about assessing the cricothyroid membrane as well? The patient could be obese, yes. Even in obese patients, the cricothyroid membrane is palpable, okay, and with ultrasound, even more so. Yes, awareness of false track. Somebody has brought in a very valid point that if the bougie doesn't scratch the tracheal rings and we don't get that scratching feeling, there is a possibility that it could be. So hence doing this procedure technically appropriate is very important, and that can be practiced so that we can avoid a false track. Okay. Yeah. Air aspiration. Yes, we can do that too. We call it as a Seldinger technique. So if we are going to use a commercially available cricothyroidotomy set, in that case, we have to use a guide wire. So we puncture the needle, we aspirate with the syringe, confirm the trachea by aspirating air, and then put a guide wire, a thin, like the central line guide wire, through the needle, remove the needle and railroad our cricothyroid cannula over that. So that is a commercially available cricothyroidotomy set, which is there called Melcares. Okay, but it's expensive. But yes, it could be in our crash card or in our bag that we can use. So bougie 6-number tube and surgical blade is the most simplest from the equipment perspective, cheap and immediately available. Melcare set, if you have, you can practice the Seldinger technique. So in fact, FONA, we teach 3 techniques. One is the Seldinger, one is the bougie technique, and the other is there is one more set which is available, which we can use and show you that. A formal percute tracheostomy in expert hand, within 10 minutes we can achieve that. Yes, somebody has mentioned here as a percutaneous tracheostomy. But remember, percute track takes time. It still takes, in expert hands, minimum 10 minutes. Okay, we may not have that much time. Okay, how long can we ventilate through this? Excellent question. I think the challenge of ventilating through this is tough. But if we put a 6-number tube, we will be able to umbu the patient through this. If we have a percute track also, we can umbu, but we cannot umbu through a needle cricothyroidotomy. Yes, there complications are there. There is a chance that the ET tube could pierce posterior wall, and hence learning the technique is very important, so that we are sure that we are able to perform the procedure even under that pressure of hypoxic sound from the monitor. And that's why practicing in simulation is very important. Okay. So please remember that if the track is wrong, it bleeds. See, anyways, we are not going to do this procedure electively. We are going to do this procedure only when this patient is really do or die situation, CICO. Okay. And that case, giving a chance to the patient when you are trained, I think is completely justified. Yes, we can ventilate through the percute tract. That's agreed. Obese patients are going to be challenging, and hence their airways need to be evaluated. The cricothyroid membrane can be marked. We need the whole gadgetry when we are intubating them. So yes, there will be challenges, and we can overcome with training, with keeping the equipment ready and having a team training. In fact, you can bring your technician for the training. You can bring your nurse for the training, so that as a team you can practice. Okay, so we will go to the next thing. This is the entire IDA guidelines that we see. So today I would like you to answer this last question for the session. What is your take-home message about unanticipated airway management that you take home today from this simulation scenario, so that in your private practice you will remember how I can improve my practice? Practice FONA. You are all welcome. So many simulation centers are there. Just contact us and we will train you on FONA. Training, training, training. I think this is like the mantra. Excellent. Okay. Prepare in best way. Prepare for the worst. I think the more we anticipate what all can happen and be ready for that, even in the court of law, we are justified that we did what was right. Okay. We got trained and we did what was right. Follow the IDA guidelines. IDA guidelines are beautiful. I would request you to go online and check. There are multiple guidelines, not only for adult patients, but also pediatrics, also obstetric patients. For intensive care, there are various guidelines of IDA for the airway of all these patients. Cognitive aids. Yes, pasting it there so that if we don't remember, we look for it. Paste DAS guidelines or IDA guidelines in our OT. Okay. Train our teams together in simulation. And see, panic is normal. Okay, panic is normal. The more we say don't panic, we are going to panic. Okay, so just accept that I'm panicking and do this mindfulness exercise that I'm panicking and I just can't think, and say it is normal to panic. It is okay to panic. Give yourself permission. And psychologically, the panic automatically starts spiraling down. Yes, LMAs or iGels with you as a freelancer, because these are our rescue devices. We need them with us. Retrospective problems. Okay. I think debriefing your critical incidents. Every time you come across and you overcome that, as a team, come together at the end, once the case is done, and think, next time ye hua to, what will I do? Okay. What can we do? And I think preparing for that. Intubating LMA is also a very good investment, but please remember, intubating LMAs are expensive. So buying it as a group is also a good idea, so that one person can have and we can call for it. Never enter OT without having a cup of tea or coffee. That's a good day. So a day that started good may turn sour any time in anesthesia. Okay, yes. Okay. And should be confident to and always call for help. I think nobody is perfect, and that's the dictum. Okay, and it is not about us being perfect, it is about patient being safe. So it is okay to call for help and help each other. Simulation training centers are not available everywhere. They are. Okay, they are. Yeah. You just let me know where you are and I will let you know which sim center you can visit. Training the mind for critical thinking. Yes. Our mind is very powerful. We can pass exams, we can do everything. So, but just that the cognitive overload makes us think that we won't be able to. But we can master that too with time and practice. I think this is the last slide of the day. I would request Dr. Anita to take over the session, and I'm going to stop sharing at this moment.
Thank you, Dr. Vaibhavi, for an excellent tour of the simulation, and we all were very excited to take part in your this whole scheme of online. I mean, it was very difficult for me to imagine how in an online webinar we can participate, all our members can participate, and it was very good. I'm very happy that people could really participate.
Yes.
Like the gist of it.
Madam, it's almost a workshop only today.
Yes.
Because right now I work for a bigger hospital, Dinanath Mangeshkar, but I have freelanced for 4 years. So I have been on the shoes. I have been in the same problems that I've come across, difficult airways, and you won't believe how much my bag had, everything. And I used to feel I'm a walking, talking hospital. Okay. So I know it is a lot of investment, lot of stress, but I think saving one patient, I think we can sleep better. We really deserve that at this point of time.
Yeah. You stimulated us to work on this simulator.
Yes, you're most welcome. You just call me anytime. We will arrange a session.
I have decided now to visit Nasik local simulation center as Saudi.
Yes.
I'm going to come and learn FONA.
All sim centers
FONA
will
with
have.
Saudi,
Yes.
I just want to add one thing. I'm sure many of the faculties over here who attended today's session are thinking how we can practice this. I was also at that stage, and I was very fortunate to visit Dinanath Mangeshkar, where I met Dr. Vaibhavi madam, and she gave me one kan mantra. She said, see Savni, it's not necessary to have mid-fidelity or high-fidelity simulation to start practicing simulation. You just start with whatever you have, try to create scenarios. And those were the words which promoted me to create some scenarios in the OT. And gradually I found out there are many things. See, there is no syllabus to the simulation. There is no end or there is no protocols. You have to go into this way only. And as we start practicing it, it's like a magic. So adult task trainer can create some 10 to 15 scenarios I never imagined. So, and even to the faculties or to the trainers who are thinking, how should we invest? So there are very simple ways we can create the simulators. So many of the people have used orange skin peel to practice skin suturing. Then they have made CPR dummies out of cushions, then boxes or the plastic bottles, and where they are actually training people how to give chest compression at the right side. So I think Vaibhavi Madam's Kana Mantra has helped me a lot, that we have to think whatever available resources we have and whatever we can do our own imagination, and whatever is necessary for our own setup, we can easily create with the help of, and Vaibhavi Madam is always there to guide us. So I think everyone should start. Just starting is the problem. Otherwise, we can definitely move ahead.
And
Thank you.
all the training programs that are there, all the websites of all sim center will have those dates of training program. You should access all of them and see when possible you can attend. But you're all welcome.
Can we go for question and answer?
There are no questions. Actually, everybody just praising, lot of praises in the chat box, but no questions. All our questions are answered by Savni and Vaibhavi.
Madam, I have one question.
Yes, please.
Hello. Yes.
Yes.
I just wanted, Madam, you showed very nice video. Are those videos available for simulation to teach PGs or use them?
Yes, they are there on YouTube. Our anesthesia department and sim center collaborated and they said, let's make those videos. So they are available on YouTube. You can access them.
It's a Dinanath under name of yours or?
My name. Under that, you will find all these videos. In fact, many more. For tracheostomy also we have. For nurses we have. So feel free to use them.
Oh, thank you very much, ma'am. That's great.
Welcome.
And what about the live simulation programs, madam?
In fact,
these are conducted at your hospital?
Yes, sir. ISA, like Anita ma'am mentioned, ISA has started a nationwide anesthesia simulation program, which is a one-day workshop, which has all this. It has FONA, it has intraosseous access, it has defibrillation, cardioversion, pacing, infusions of different emergency drugs, how to make right from a bottle to a syringe pump, all these emergency skills that we want to know. That program is there. So this program will be announced soon in Pune, and I will keep you all posted when it comes. But even before that, if you wish, you are a group of 15, 20 doctors who are keen to do a training program of one day, just let me know. I will arrange on a Sunday, which will be convenient for all of you.
Yeah. Okay. Thank you very much, ma'am.
So don't wait for me to announce. You tell when you want, and we'll do it.
Definitely, ma'am.
Yes, we have Dr. Rajendra Patel here, who's also working a lot in simulation. Sir, you can unmute and we want your comments.
Yes, thank you. Thank you very much, Aya, for unmuting me. Because at home, I'm always at mute mode. But anyway, jokes apart, excellent presentation from Savni. Savni is my student, right? So, and Dr. Vaibhavi, right? They have made it very clear. I think motivated quite a lot of people now. The one question which was I think, going into Dr. Anita's mind, how come we involve the private practitioners? See, what is the aim of simulation? We discuss about technical thing, non-technical thing, everything. And what is it for? It is basically for safety of the patient. So whether it is safety in the corporate hospital, whether safety in the private hospital, it is same, isn't it? Right? So I think we should be, more and more sort of pushing this program. And I'll tell you, I'm totally into simulation for the last 2 years. I'm enjoying it now. And basically we should, take it forward to all the small places also.
Okay. Thank you, sir.
Can we arrange simulation workshop at our city branch level?
At your?
Yes. At our city branch.
Yes, of course you can.
Can you all? can you all come with simulators?
Yes, we can also locally arrange it. I think there are certain companies who do provide those. So we can let you know, you can contact them and they bring everything.
Okay.
Yes.
That will be better. Yeah, I think that will give more exposure to the peripheral city branches.
Good evening, Patil sir. I would like to say Patil sir was the one who took me to Vaibhavi madam. So the start and the origin was from Patil sir. So thank you so much. Thank you so much.
Yeah. Can I just take 1 minute?
Yes.
Yes.
There
Only
is- there
1
is a-
minute is remain.
Yeah. Only 1 minute.
For 8:30.
8:30. Yeah. Only last 1 minute. Okay.
Yes.
I'll just tell you one short story. 50 seconds. Okay. Let us see. Right. एकदा काय झालं ना, somebody, there was a lot of rains and one small boy fell into the well. Okay, and तो
Okay.
गडबड करायला लागला, हे करायला लागला. Nobody, it's quite raining heavily, right? Luckily, one young chap put him, put inside the well, and he saved that chap. So everybody was, clapping. Ki kone, and he said, that is all right. But tell me who pushed
Who
me.
pushed me? Yeah.
This was actually me. The Samani is, so I just, wanted to push you.
But it is not a well.
Yeah, this is not a well, definitely.
Ma'am, can I ask you, madam, in Pimpri-Chinchwad, where can you arrange? Because there are a lot of people, nearly 150 anesthetists practicing in these areas, and we have got a large branch almost. So where can you arrange a simulation? Like going to Bharti is a bit difficult to travel all of us there.
Yeah. Sir, I think Sarankade solution hai.
Madam, you got simulation lab next door. DY Patil.
DY Patil.
Yeah, they got a beautiful, simulation lab, which is not far from your place also.
But the trainer,
They want faculty, you mean?
yeah.
Yeah, faculty, you can talk to Dr. Vaibhavi or me, we will all arrange. No, not to worry.
We will come. So venue is there, simulators are there, and we can travel.
So this is a very good idea. All those city branches of SAMS that do want to arrange for a simulation workshop or one-day workshop at their places, please contact us, Dr. Rajesh or me, and we will facilitate this. Like we will really like to take this forward. And we do have centers all over Maharashtra, so we can arrange for these workshops.
पाटील सर, गुड इव्हिनिंग. सर, माया बोलते. सरांनी खूप सुंदर वर्कशॉप घेतला होता आदित्य बिर्ला मेमोरियल हॉस्पिटलला आपल्या IMA साठी, आणि हाय फिडिलिटी मॅनिक्विन्स मला वाटतं आपण चेन्नईवरनं मागवले होते, आणि इट वॉज एक्सलंट वर्कशॉप सर. तर तसाच जर आपल्याला कुठे प्रायव्हेट सेटअप मध्ये जर घ्यायचं असेल किंवा दुसऱ्या हॉस्पिटल्समध्ये घ्यायचं असेल तर त्याला साधारण कॉस्टिंग काय असू शकतं? म्हणजे समजा आता आमच्या सिटी ब्रांचला घ्यायचंय, DY पाटीलला आहे किंवा मायमरला आहे, पण जर आपल्याला अजून दुसरीकडे काही घ्यायचं असेल तर त्याला कॉस्टिंग साधारण किती?
Right. No, basically you have to tell us what are your requirement, in the sense what type of workshop do you want? You want obstetric anesthesia, you want pediatric anesthesia, you want inhalation. So depending on that, the costing will differ basically. But it's not much actually. So we can easily get sponsors also.
Okay. आणि with the registration charges आणि some sponsorship we can manage that. म्हणजे at branch level I mean to say. Okay. Yes. Okay.
I think the model developed by ISA National is very good. They have included all these, things which are very important life skills like FONA, and so it's a good module. We can. Do we need a high fidelity mannequin for that, Dr. Vaibhavi, for doing that ISA National module?
See, in fact, we just need one. Okay. Rest others are task trainers. So that also there is a company who will bring in all that is required, and that budget, everything, the whole package is ready. That means you don't need to worry. You just have to have local faculty, some space, all the equipment can come.
Yes, now many conferences have this simulator workshop day before the conferences. So they are available now.
Yes. Yes.
So in
Can I
short,
talk
you
for a
just
minute?
have to ask for it.
Yes. Whatever you want, it is there.
Yes, yes. Great, great.
Excellent.
Can I talk for a minute? Can I talk for a minute, please?
Yes, yes, sir.
Sorry for this is a great congratulations to organizers and congratulations Dr. Vaibhavi and Dr. Sally. Sorry. Now what? Generally, we get lots of difficult intubations or unnecessary difficult intubations in nursing homes. The first person available to you is some technician or a staff nurse or anesthesia, So always keep all gadgets. What I experienced, people have gadgets, people have laryngoscope, people have video laryngoscope, but they are kept in a bag. So best is keep them handy, put them properly on a trolley, and the tech. What exactly he has to give next in case he fails. And best is never start anesthesia unless surgery is next. Nowadays, it is a very big trend that surgeon मी गाडीत आहे मी घरातून निघालो anesthesia चालू कर. Please request them, excuse me, we had lots of troubles where the surgeon was parking car at some other place and the patient was VVIP, anesthetist could not intubate. Fortunately, he was accompanied, patient being VIP accompanied, patient was accompanied by a surgeon who was a thoracic surgeon also. So they abandoned the surgery. Next day, the surgery was done with the sedation and regional anesthesia. So for nursing homes, keep all equipment, whatever you can, keep them handy. Buy a borrow still. Keep a good technician. Always train a technician to have how to give suction, how to put. If you are not familiar with this tracheostomy, keep a big thick needle handy, about 16 or 18 gauge. Just put a cricothyroidotomy and make it ventilate the patient to venture. That's the smallest thing which we have. Some of the people have, but people have lost the patients on table because they could not keep the things handy, or even if they were available, they were not keep ready, and the technicians were not trained. So thank you very much. Sorry for this, and I think we should give simulator workshop to our technicians and surgeons also, because it's the assistant who is the most important at this particular stage.
I think Dr. Maya Bhalerao and her team are conducting this sort of workshop for the OT technicians at Pimpri Chinchwad. Paramedical.
Yeah, paramedicals. They have taken.
Yes, yes.
Yes, yes.
We have
Even at
conducted
Nashik,
twice, guys.
even at
आणि
Nashik,
आम्ही
we do conduct for OT technician. Yes. Basically, the idea is you should go and learn simulation, and then you go back to your, because everybody will have a different set of people, members in the OT. So you go back to your own OT and then you conduct your own mock drills, simulation sessions with your own assistant, staff, surgeon, and you keep that in mind that if such situation happens, whom I am going to call. You have their names in your in your phone. I mean, should be able to tell your surgeon or somebody, okay, call this person as a call for help if you're going to be a single anesthetist in the OT. So all these things you should think beforehand, and then this will be useful, as Dr. Vaibhavi said, 3 things. What am I feeling? Panic. Then it's okay to feel panic. And what was the third thing?
Is saying that in spite of I be feeling the panic, what would I like to do for the patient?
No.
This is like an internal conversation that we do. And I have seen that it really helps us calm down because we acknowledge, hey, panic zale me, admit, accept, So then the panic kind of reduces.
So thank you very much.
Madam, in the take-home message, you should give a message that always buy good equipments because they are available in every conferences. Like good equipments. Instead of buying, investing in the gold, we should go for better equipment because these are the lifelong assets for us, isn't it? That's what I feel because every conference I go, I find something new and I buy and keep in my bag. My this one car is full of gadgets at the backside. Wherever either the pediatrics, geriatrics, whatever the thing may come, ventilator. Even with I got my own ventilator. So wherever I go, these are the gadgets which help me, and that's how I survived for last 44 years.
Yes, great, madam.
Yeah, all these video
Your
live.
enthusiasm is contagious.
Next time you buy a simulator also. सगळ्यांचा problem solve होईल.
All possible equipment.
And all these equipments, including for video laryngoscopy, do have a
Madam,
learning curve.
even we were working without machine. That was the era of 1984, 82. The first boils came in 1982 to the Pimpri Chinchwad. Till that, there were no even boils apparatus. We were working on the Dabba Batli, similar. So from that era, I had come to the fiber optic intubation. So this is my learning curve, and we recently had conducted a USG workshop, Sonovision. That's what, and we have trained people. I mean, faculties. We were the faculties, and we have trained students. So this is what my journey, right from with no machine till Sonovision.
Great.
Excellent.
I think
are you
we
in
have time to conclude now.
Yes.
Yes.
Let us conclude. Yes, I request Dr. Rajesh to please go ahead with vote of thanks.
Yes, excellent symposium on simulations in anesthesia by SAMS. Dear SAMS members and esteemed guests, I would like to extend my heartfelt vote of thanks to each and every one of you for making this SAMS symposium a grand success. Our sincere gratitude to our esteemed speakers, Dr. Savani Phutane ma'am and Vaibhavi Upadhyay ma'am, for sharing their valuable insights and expertise with us. And it has definitely enriched our knowledge of simulations in anesthesia. We are also grateful to our chairperson, Dr. Sunita Sanklesha ma'am, and for their able guidance and moderation. And I'm also thankful to Dr. Rajendra Patil sir, who always inspires us for simulation workshops and all. Thank you, Dr. Rajendra Patil sir. To all the SAMS office bearers, Dr. Anita Nehte ma'am, the President of SAMS, Dr. Avinash Bhosle sir, President-elect SAMS, and Dr. Saurabh Barte sir, Vice President of SAMS. Thank you for your tireless efforts in making this event possible, and appreciate your commitment to the SAMS. Lastly, all the SAMS members who have participated and engaged in the symposium, thank you for your enthusiasm and interest. Your presence has made this webinar worthwhile. Thank you so much. Thank you all.
Thank you very much.
Thank you. Thank you.
Thank you, madam.
Thank you. Thank you. Good night. Good night, everybody.
So that was great.
I joined from US.
And nice to see Pramod.
Want to arrange the
Vaibhavi
simulation workshops.
and Dr. Rajesh.
We really take
Both
this
of you are in
forward.
US. This is early morning here. Sorry, it's very pleasant. Thank you. Okay, chalo, thank you. Thank you very much.
Sir, where are you,
There is
sir?
a video. I'm in San Francisco, sir.
Oh,
Ah,
Oh, yeah, it's early morning here.
yes. Yes.
उधर से इंडिया कैसा दिखता है?
अरे सारे जहाँ से अच्छा.
सारे जहाँ से अच्छा.
India is India, boss.
Yes, सारे जहाँ से अच्छा हिंदुस्तान.
Come back
है.
soon.
Come back to आता ही है सारा.
Okay,
India का
thank
की
you.
मजा नहीं. India. I had been to hospitals. I'm going to a regular hospital as an observer, very big hospital, and they would like to. They listen to what we talk. Let me be honest. They listen to. They have got more than 100. I will just share if you have time. They have got more than 120 theaters working at a time. Actually, hospitals OT चालू असतात at a time. It's a teaching hospital, and there they have a regular and then actually they have got a difficult intubation trolley and all these things. But they would like to listen because in something in that 2005, I showed a video film of this thing, Trufatec video laryngoscope.